Achieving a balanced lifestyle doesn't have to be a dream, and wellness doesn't have to be an activity you save for downtime. Instead, elevate your personal and professional life with the tips, tools, and insight to holistically support healthier habits. Join me, Dr. Callie Davis, in the Mind-Body Connection for enlightening conversations, inquisitive panel discussions, and illuminating stories from experts in the medical and healing communities who are leading the movement toward a holistic approach to health. Welcome, everyone, to the Mind-Body Connection. We're so excited today to have Dr. Joe Mather back with us. Dr. Mather is a friend and colleague, and he is an expert in functional medicine. He helps people around the world to figure out complex illness and to problem solve chronic disease, including chronic gut issues and mold and Lyme disease and a lot of really complicated stuff. So I really respect Dr. Mather's knowledge base and his caring approach with patients, and also his way of working with colleagues that it makes it really fun and interesting all the time. There are so many things that I learn on a daily basis, just interacting together. So tonight we are going to focus in on this topic of Mast Cell Activation Syndrome. And I'll leave it to Dr. Joe to introduce us to what MCAS is and the implications of it and what we can begin to do with it. So I would love, as an audience, if you come away from this podcast with a deeper understanding of how to help yourself if you have MCAS.
Hey, Kelly, thank you. I can't wait to talk about MCAS because this is not something that is taught in medical school. And a lot of patients are suffering with this. And so anytime I get a chance to kind of introduce a topic and share my experience treating patients with complex illness, I love to do it. So maybe the best place to start is just a general introduction and what is MCAS?
Yes. Definitely, because there's probably people listening who are like, what is MCAS? That's just a bunch of letters. And then there's probably people listening who are like, oh my gosh, I cannot wait to hear what they're going to say because I have MCAS.
We doctors love our letters and acronyms. So MCAS is Mast Cell Activation Syndrome. And it's an umbrella term for a lot of symptoms. And so it's very easy for patients to look up symptoms online and then say, oh my God, I have MCAS, where they may or may not have it truly. But the thing that I am always looking for when I'm trying to evaluate if someone has MCAS is immediate reactivity to food, drink, supplements. In the worst case, people have MCAS when they swallow a glass of water. So if patients are reacting to water, then we know for sure that very likely to have MCAS be part of the issue. So the mast cell is an immune defense cell, and the mast cell therefore is clustered in the spaces of the body where pathogens can get in. So I think of it primarily as a cell that lines the GI tract, but in reality, they surround blood vessels and they surround pulmonary tissue, major entryways like into the body. In my practice, perhaps because I do a lot of GI medicine, I see that association with eating, taking pills, and then the reactivity from the mast cell. So the mast cell's job is to protect against pathogens coming in. And you can think of it like a mini grenade. And inside that grenade has a bunch of different fragments, and those fragments may be all sorts of chemicals that cause inflammation. Mm-hmm. So that would be histamine, that would be cytokines, that would be interleukins, all of these very small chemical messengers that when the mast cell explodes, creates a localized inflammatory and immune response. Mm-hmm. And so the mast cell, the core of a mast cell disease, is someone having an upregulated inflammatory and immune response to their environment.
Yes. And I think about that, like inflammation, right? It's become such a layman's term in our modern world. Yep. And it takes a lot of hit, right? Like, oh, it's inflammation. Yeah. So inflammation, we have to remember that our bodies heal through inflammation at a controlled rate, like at a dose that is good for our bodies to heal, right? So inflammation is part of cleaning up some damage naturally, internally.
Yes.
And then we have this other like runaway train of inflammation that can cascade and lead to all kinds of yucko symptoms.
Yeah. So, you'll need some inflammation when you strain your muscle and you're building muscle if you're strength training. But the inflammation in mast cell disease is symptoms. And classically, we think of symptoms in 2 or more organ systems, right? So you can't just have joint pain and say, I have MCAS, right? Now, if you start eating foods and you're having palpitations, flushing, diarrhea, right, and joint pain, then all of a sudden that's very likely to be mast cell because you have multiple organ systems that are responding to the mast cell degranulating, releasing all those chemical inflammatory pieces.
Yeah.
So we have, again, the core of it is people are reacting to their environment, but it's not just necessarily foods or things that they swallow. Sometimes it can be other environmental toxins, right? And so the next big piece is, why does this happen, right? And in my experience, in my practice, there are 3 main drivers. One are predominant GI problems, so bacterial imbalances in the small intestine or inflammatory bowel disease. The second would be exposure to mold toxins. And the third would be heavy metals, right? There's a bevy of other chemical exposures that can do this. I've had a couple patients with off-gassing from spray foam insulation, freon leaks from a refrigerator, carbon monoxide. So there are other things that can do this, but just generally GI, mold, and metals. Those things are very, very toxic to the body. And so it sends a very, very strong signal that the body's under attack.
Yeah.
So what the body does is it sends messages to the mast cell to be on guard. And this is what makes these guardian defense cells just hyper-reactive, right? I like to give the analogy that you can think of the body having like a military headquarters in the brain. And normally, you're not on red alert, and the immune defense in your gut is just like a mall cop, right? He's eating donuts. He's not doing anything really. He's just kind of sleeping in his chair.
We're not telling anyone to eat donuts, okay? We're just comparing.
Unless you're in New Orleans, then you have as many beignets as you want. But so then if you move the environment to a water-damaged moldy building, right? Mold toxins, gliotoxin and ochratoxin, many others are very, very inflammatory and toxic, neurotoxic to the brain. So the brain feels damaged and threatened. And so all of a sudden the military headquarters, right, the limbic and amygdala goes on fire, and it's a red alert. And you've got that red siren, wailing, wailing, wailing. And then the military headquarters says, we're firing the mall cops, send in Navy SEAL Team 6. And all of a sudden you got guys machine gunning the food court, right? They're tackling grandma.
Yeah.
They're zip tying grandma down, and then patients are left with all of that inflammation.
All hell breaks loose.
All hell breaks loose.
And is that when that's concurrent with them feeling really sick?
Exactly.
And like going to the bathroom all day. They can't work anymore.
Yes, that can happen.
Okay. And how do you see it present? Like, I know it presents in so many ways. I'm fascinated by the different ways in which it presents, because you're right. Like, it's like they become, in their environment that they're in, they're hypersensitized to it.
They are, yep.
And so it's this kind of being not safe in your own environment. Being
not safe in your environment sends a very strong signal that the body's threatened, and one of the major defenses is the mast cell. So mast cells can do a lot of things. There's a great book called Occam's Razor, and this was one of the first books that really got me to understand what MCAS may be, and if it was wrong with my very sick patients.
And how do you spell that for our audience?
Oh, geez, you put me on the spot. I think it's OCCAM.
Okay.
Occam's Razor.
Okay.
And there's a bunch of symptoms listed in that text, but in my experience, it's typically the really big red flags to look out for that you might be dealing with MCAS is immediate reactivity, right? So not you eat something in 24 or 48 hours, you're having some sort of symptom. It's within 5 minutes. It's very, very cause and effect. That reactivity is usually random, right? So it might be breakfast one day, it might be broccoli with dinner another day, right? There really isn't much rhyme or reason to this, right? It's not a consistent food sensitivity, right?
Right.
There's no pattern, so people are driving themselves crazy.
Right.
Okay, so that's one big piece. Another is what we call chronic idiopathic urticaria, CIU. So these are disorders of histamine, and patients are getting unexplained bouts of chronic hives. And they can be huge whelps all over the body, or they can be little tiny small macules and papular rashes that are very itchy, very disturbing. They come in weird patches throughout different parts of the body, and they can be unending. That is, in my experience, very, very highly associated with MCAS. So if you're dealing with chronic idiopathic urticaria, you should definitely be checked out for MCAS.
And that would be someone who just keeps breaking out in hives.
Correct. They usually have hives all day, every day, and they flare.
Okay.
The other big symptoms I'll just list real quick. Joint pain is very common, palpitations, and periods of elevated heart rate after you eat, headache, fatigue, brain fog, flushing, and diarrhea. I would say those are the top 8 or so symptoms that I see. There are others, but those are the most common.
How many symptoms do you think present in a person, like on average? Are they coming at, like, I can imagine if you're eating something and then you get really flush and break out in hives after, that would probably send someone to the doctor, right, to figure out what's going on.
Yeah.
But what other symptoms?
Okay, let me answer it a little differently, if that's okay. So when I have someone and I'm kind of thinking, do they have MCAS or not, and is it something I need to treat, I ask them how many meals they eat in a day, and then I multiply it by 7 to get how many meals they're eating in a week. So they tell me 2, it's 14. And then I say, of those 14 meals, how many of those meals do you have symptoms within just a few minutes of eating?
Gotcha.
Right? And so if someone says 1 to 2, it's probably not worth making a big deal of. But when they get over that 50% mark, and particularly when they're saying, oh, yeah, well, it's like 10 or 11 out of 14, or every meal, then those patients need the more aggressive treatment. Whereas the patients, if they're below the 50%, sometimes you can work on the gut and the fundamentals and they get better. And then keep rechecking them, right? So if you've done some gut work and they're still hanging out and reacting to half their meals, right? That's when you're like, okay, maybe I need to add in a mast cell protocol.
Got it. Okay, so
you can also use that to track if you're doing the right treatment, right? So
nice.
If they say I'm reacting to 10 out of 14 meals and you put them on a program, you would expect that number to drop, right? You want to see that 5 or 6, in the next month, and the reaction should be less intense.
Yes.
That would tell you that, yes, you're treating MCAS the right way.
Yes. So that the number of incidents that they're reporting is decreasing even through the week.
Yeah, so I would see them probably on a 4 every 4 week kind of cadence. And if on a successful MCAS program, you're dropping the symptoms at least 50%, right, in the first month on average. Some a little slower, some a little bit more, but the patients who really have MCAS and you're hitting it the right way, they will email you very quickly and say, oh my God, I feel so much better.
Relief.
Yeah, right.
Wow, I love it. I love it. So let's talk about treatment options.
Sure.
I really would love, because, our brains are like this. I definitely want to go back into some of the lifestyle things, because I know you are going to be like lifestyle corrective philosophies. But with MCAS, it seems like it needs a lot more specific work going on.
I haven't found, there's a couple tricks that I'll save for the questions later, but this is not something that is really fixed by lifestyle.
Yeah.
Right? You can't eat the perfect diet out of this,
right.
Even if you're sleeping well and not stressed out. This is your body's immune system, it's pissed off, it's angry, and it really needs to be calmed down. So you really do, this is a time where you really do need supplements, medications,
yes.
Active treatments.
Yes. And I have to ask you this too, because I know you're seeing those patients that have been through immunology workup, GI workup, and they're still very sick.
Yep.
And so when you get a patient like that, are they already on medications? And do you have to go through that list and weed out and change a good amount? Or like how does that go usually for you?
As a general practice, that's what I do for every patient who comes in, because almost always they're on supplements they don't need to be, and some medications they don't need to be. And these patients are so sensitive that one of the very first things you want to do is make sure nothing extra is coming into their body that they can react to. So if they're taking, 3 to 4 supplements that just aren't doing anything or moving them forward, they should just be stopped.
Yeah,
so even better starting from scratch. If someone is able to come off everything, usually works the best. That's a great question, Kelly. It's a good insight.
Yeah, because it's kind of like it's shooting in the dark a little bit, right? Because we don't know what the actual triggers are until we might have to eliminate some of that first, right? And then add something back in, and then they have a reaction.
For MCAS patients, less is more always. And sometimes the first step to calming down is just putting less in.
Yes.
And so a supplement holiday and working with a doctor to take away medications they don't need can be healing in and of itself before you even add anything else in. Absolutely, 100%.
The term supplement holiday.
Yeah.
My gut just relaxed just from
it's
hearing
on a beach in Hawaii drinking a cocktail.
So do you want to discuss medications? Is that something, or is that like too specific and individual per patient?
I think I'd rather first give a hat tip to my mentor, Neil Nathan, who taught me a lot of this.
Yeah.
And I wouldn't be able to talk about this without his knowledge. So
Great.
Thank you, Neil. And I'll share the general way that I like to start many patients on this, because I think it'll help you understand kind of how to approach this. So if you have the Navy SEAL Team 6 guy machine gunning people down in the cafeteria,
including Grandma,
Sabaro, including Grandma, you can't just like bring one person at him, right? You want a team to like group tackle him and bring him down, right? Because he's probably 6'5" and 250 pounds. So you need like a multiple people. And so you really need multiple supplements and medications at the same time. It's rare, it happens, but it's rare that you can just get by with just 1 or 2. So what I generally like to do is come at it with an H1, histamine 1 antagonist. These are over-the-counter allergy medicines. Allegra, Claritin, Zyrtec, Xyzal. Allegra seems to work the best in my patients for whatever reason. The next would be an H2 antagonist, histamine 2. These are over-the-counter heartburn medications. Pepcid works very, very well. Also, you have Zantac. If you have MCAS and you are worried that taking a heartburn medicine will lower your stomach acid, you do not have to worry about that. It does not cause any damage and can be extremely healing and helpful.
Cool.
I just say that because I'm shortcutting a lot of questions. I always get that one.
Yes.
So H1 plus H2, and then I like to use quercetin, resveratrol, and curcumin.
Cool.
And so those are kind of the first round that I throw at the mast cell. And you're kind of shutting down that grenade from a couple different places. It's not just, putting a lid on it, you're putting different walls on it and a lid so that if it explodes, you've got more coverage. So those are mast cell stabilizers that work well in combination. When I first started practice, I tried just using 1 or 2 because I see so many patients who come in and they spent 10 grand.
Yeah.
And so I want to be conservative and not make them take more than they need to. But over time, I just learned, patient after patient, it's much better to start with a full court press when there's MCAS. So that's the way I start treatment if it's just kind of going more of a natural route. And if someone with less severe symptoms, that would be appropriate. I do something different if someone is more severe.
And can you give us a picture of what that would look like? The person who's really sick.
It's my favorite medication, cromolyn. Cromolyn sodium.
Interesting.
It's not a very commonly prescribed medicine. It's old, but it's awesome. It is a mast cell stabilizer. It's specific to the mast cell. And when it works, you know that it is mast cell causing the problem.
Wow. So that gives you additional information whenever you treat with that.
Which is one of the core tenets of my practice, is that if you use a specific treatment and it shuts down symptoms, you've diagnosed it. Because
Definitely.
The reality for MCAS is the testing sucks.
Right.
It's bullshit.
Right.
So the allergists and immunologists are ordering tryptase levels, and there's 10 other levels that are really not accurate. They're not up to snuff to diagnose this. They're very labile, meaning the levels go up and down. A lot of these markers are short-lived. If you don't draw them in the right test tube, they'll be inaccurate. And so I don't draw for these or recommend that anyone test these unless you're seeing an allergist completely set up for this and their protocols are based on tryptase, right? That's okay. But in my practice, I would much rather have people spend that time, effort, and energy into just getting the symptoms down with treatment.
To feel better quickly.
To feel better.
Or as quickly as they can, possibly, with the cellular level.
Accurate. Yeah.
And, okay, so my curiosity, quercetin, tell me how that works in this case.
So it is a broad spectrum mast cell inhibitor. It's also an antioxidant.
Okay.
And so it's doing some double duty here. There is a very, very cool study, published paper called Mast Cell Inhibitors for the 21st Century, which sounds like a sci-fi spaceship or sci-fi show. But it lists the natural compounds that we have good in vitro data for that it will shut down the mast cell.
Cool.
And again and again and again, quercetin comes up on that one. Curcumin comes up on that one.
Yes.
And resveratrol. So those are the three that I start with because there's the most scientific evidence. You have to read the paper if you want to know exactly how it works because I can't remember.
Got it. But
there's receptors.
Is it plant-based? I can't think of where it comes from.
I think it's grapefruit.
Okay.
Is from a chemical found in grapefruit. If I'm wrong, email Kelly and tell her.
I've seen quercetin enough on the scene to be like, oh, I need to find out more about that. Curcumin I've been pretty familiar with because we love its anti-inflammatory effects.
Yep.
Okay, so then you're working on calming down that histamine response, regulating the gut for it to be a healthier system.
Absolutely.
The immune system then starts to not go into constant overwork. And so then they're having less reactions to their food and they're logging it like, oh, wow, I only had 2 reactions this week. And let's talk about joint pain.
I was going to say, so that's exactly the time when you want to start building resiliency.
Yeah.
So those are the patients, particularly when I know that there is an orthopedic component, I would want to send to someone like you, Kelly, because we can get the symptoms down from the mast cell from a biochemical standpoint. But the reality is most of these people have structural issues that need correction.
Yeah.
And it's because a lot of them have hypermobility.
Yes.
Joint hypermobility syndrome or hypermobile Ehlers-Danlos syndrome.
Yes.
And I would love to hear your perspective because that's where I send them down the hall to you and they go into the black box of Kelly's office.
Yes.
And so I'd love to learn more about what you can do to stabilize the joints.
Definitely. We're just going to rename my office the bendy box for now because we're all bendy in there and we're all hypermobile in there. And it is really fascinating again that these syndromes run together, right? So a population of EDS is going to have more comorbidity of MCAS as well as POTS. We didn't bring up POTS, but that cardiovascular component.
I think they're one and the same in some cases.
Yes, definitely. It's I've heard it called, the triad, the hypermobility syndrome, MCAS, and POTS together.
Yeah, some people will say dysautonomia, and all 3 of these will kind of fit in the same category. Their Venn diagrams are very close to each other.
Right. And I mean, it's just like, it's the frowny face on the pain scale chart, right? Because you have a lot of serious implications going on that are tied in together and funky connective tissue at the root of it. And so when our connective tissue is dysfunctional, then I call it kind of like weak links in the chain. Our ligaments around our joints are going to be weaker in some states. Some ligaments are definitely going to take the brunt of it and be higher risk for injury through a person's lifetime. And this could be the joint having less stability, but it's also combined with higher inflammation. So take a joint that you can, move a lot more than it should be moving, and it's going to open up the risk for injury to the tissues, but then it's also going to give it another reason for staying inflamed.
I've always wondered, if you have a hypermobile joint, do you think it sends a signal of instability from the vagus all the way up to the brain? Right? Is that another level of someone is not doing well because their body doesn't feel secure in space?
That is a great question. And the way that we've looked at it is more of what information is coming in from that unstable joint, and it's inadequate. It's not enough information coming in from the joint.
Oh, because it's hypermobile.
Yes. So our proprioception, which is our ability to discern what direction that joint is moving in, how fast it's moving in, all the mechanics of that joint, that information that's fed back to the brain in a normal connective tissue situation is helping the brain to control the joint properly. But when we are lacking that sensory feedback information from it, we don't know how to control it inherently. It's not a conscious process, but it's because we're not receiving enough feedback from the joint. So interestingly enough, it's harder to train a joint like that to be stable. One of the treatment approaches we use in therapy is to enhance proprioception in any way possible. So body awareness, even just mindfulness, tuning into the joint will give us extra sensory feedback there. But also things like weighted vest or tactile pressure sensation, putting hands on a joint so that you can tell more about where it's moving and what position it's in. So it's like giving more feelers to that unstable joint. And that in turn builds up the pathway. Better feedback happens, better coordination happens. And that's how we can gain stability. So I love that question.
Cool.
It's always a dynamic interchange between what the brain is receiving and what the joints are doing in return. So with our joint pain, let's say you have like just knee osteoarthritis and your cartilage is wearing down, but that has been diagnosed independently of these other cascade problems running in your autonomic nervous system. Like EDS, hypermobility in general, and the MCAS. So it's going to be a lot harder to control for that osteoarthritis flare-up because of the mechanisms at play, including our gut, including our immune system, and how histamine would normally play a role. When things are escalated and the chain reactions out of control, then the flare-ups can come more frequently and be more severe.
I see.
So someone with osteoarthritis that might be able to get on a bike and manage their symptoms by moving the knee might not be able to move that day because the pain is too severe, their flare-up is too severe, their knee is swollen. We're talking like levels of acute inflammation that we wouldn't normally see in a regular knee osteoarthritis situation.
That is interesting.
Yeah. So, and it looks like, histamine response. And so we want to equip patients with all of those things going on with calming nervous system methods. I call it a first aid kit for pain. Sometimes they're going to need to use the NSAIDs that the doctor has recommended or steroid if a doctor has prescribes.
Yep.
To be able to knock that inflammatory cascade down a bit so they can walk.
I have to convince my patients sometimes to take NSAIDs. They're very anti-medication sometimes, but there are times when they're absolutely appropriate to use.
Yes, totally.
And so in the hands of a good doctor, don't be afraid.
Yes, because, if you can't move that joint because it's hurting so bad and it's swollen, we've got to do our best to be able to get to the level of function where we can move the joint because that's how the joint's going to heal through movement. So we want to be able to restore some pain-free or pain-reduced motions. And once a patient can get through a flare-up and move again, it's always, lower dose and then increasing slowly, gently. The things like walking or getting in a pool or soft tissue massage, all of those gentle, feel-good things, they're going to calm the nervous system too. So it's going to have...
That ties in a lot to where I try to get patients after we've put in the first level of treatment to calm down the mast cell, because when the red alert from the Army headquarters is going off, you need to give all of the support for resiliency that you can, right? So it may be orthopedic work, it may be mindfulness work, it might be just not being in pain, it might be making sure you're not being exposed to toxins, or it might be limbic repair work. And so patients who have a disorder in the limbic system, the way that the limbic system will manifest itself is through the mast cell. And I know that because I've seen patients do limbic retraining and their mast cell activation went away. They did the Gupta program for 2 months and all of a sudden did not need the H1, the H2, the quercetin, the curcumin, because the limbic system was the one sending the message to the Navy SEAL Team 6 to open fire.
Yes.
And when you got that sense of calmness, of stability, of joy, right?
Yes.
When you stop that cycle of really harmful, negative talk, self-talk and thoughts that we can have when we're sick, then the mast cell will calm down. So it's important that there are physical causes to this, and then there are, environmental toxins. There's the gut, right? There are true physical things, but there's also the limbic system that gets closer to the social cycle, like more of the really deep kind of psychic injuries people can have.
Yes. Let's talk about that. I think that is so current in our world right now. As providers who are holistic in training, we need to be able to recognize where there are cases.
People with elevated ACE scores, childhood trauma, tend to always get MCAS. Not always, but I would say 50% of the patients who come in with MCAS, when you ask them, they've been abused, they've been neglected, they've had sexual trauma, and it's just maybe more common than people might expect. And so that's just another red flag for the development of limbic problems and subsequent mast cell problems.
Absolutely. It's what we hit on earlier about safety. If your
body doesn't feel safe.
Yes. And so I think healing from trauma in that emotional realm and the psychosocial realm, it requires us to be able to heal from those past wounds and to be under the hands of providers who recognize that, who don't dismiss that part of us.
Yeah, so those of you with MCAS, I hope that you're taking away that this really should be a team approach. When someone comes in to see Kelly or myself or another practitioner who's familiar with MCAS, you're going to do best if you can find a group of people who can help with different needs. And everybody will need a little bit different pieces here, but MCAS doesn't just happen, right? There's usually several layers that you can peel away with these patients if you go deep.
Unpacking the whole person. And I would love to shout out to Dr. Aline Salou. We both love her. She's in New Orleans. She does a lot of wonderful trauma work. And understanding that full healing can come from that team of providers. And sometimes we have to go outside of the traditional medical model to find people who can really help in those aspects of care. So I'm so excited. We have some questions from a group that I posted on Facebook, and it's called Talking Heads, HEDS, for hypermobile EDS.
All right. I like it.
And so here we go. Our first question is, any advice on how to treat flares with limited medication use?
Yeah, so I think this is someone who wants to minimize the medications coming in and wants to treat flares. There's not much that works here, is the honest answer. People always kind of want a bunch of supplements to fix it.
Right. The
And
natural.
I find that this is something that really needs to be suppressed on an ongoing basis. And that's first and foremost. But I will give the one thing that I found to work, which is potassium bicarbonate.
Cool.
It's a supplement called K plus Alk from Moss Nutrition. And I've found that 2 capsules 3 times a day, when someone's in a flare, can shorten the flare. But I've really only used that when someone is already on a program and then having a flare on top of that.
Uh-huh.
So that would be my general answer to that.
Yeah. So like foundationally, you're going to use the pharmaceutical agents that you need in order for the system to come back in balance, because natural supplements can't do that kind of potent work.
MCAS is bad.
Yeah.
There is a lot of inflammation that is kind of always going on in the background. And if you let it up for just a moment, you're going to slide backwards. And this is why I spend a lot of my day telling patients to take things twice a day.
Yes.
So if I have them on Allegra, they're on Allegra twice a day. And the dose may differ, but if you just take it in the morning, by the time the evening, overnight comes by, and it's next morning, all of the inflammatory response has risen, and then you're back to where you started.
Great to know
it's
that.
so critical to space your program out twice daily.
Yeah. So chemically, this cannot be like, tiny little baby steps. It needs to be put the fire out.
You're not going to vitamin C and choose your favorite antioxidants away from this.
Right. Okay. I think that's great to hear. So next question, how to navigate MCAS diagnosis when the immunologist doesn't believe it's a real diagnosis or condition, especially in areas where there are limited providers to choose from?
This is actually easy, and it's get a new immunologist.
Yep.
If you're not working with a doctor that you trust, then you're not working with the right doctor.
Absolutely.
There's so many avenues, from telemedicine to traveling to see experts, that this day and age, that you just have to go see someone you trust that has experience treating your problem. And that's the only answer I can give. Life is too short to be blown off by doctors who are not up to date on medicine.
Totally. And you, Dr. Mather, are accessible virtual appointments online through your website.
If you live in Texas or Louisiana, if you live in other states, then you do have to come travel to see me. Then we can work remotely.
Got it. And so MCAS diagnosis, I like what the question poses, because how many immunologists out there do you think are really on top of their game when it comes to MCAS?
I'm kind of in my bubble seeing my patients, and I'm not keeping tabs on the immunologists. I don't know. Probably more are going to be more and more, I think, as we go on, allergists, immunologists, general practitioners, GI doctors, year by year, more will be hip to this and understand and start to see it, because it's here. It's not going away. It's a fundamental condition in the human body. So
yes. And when they start training our medical students that there is an issue with the amygdala and the limbic retraining, and it can be trauma-based, then we've made a huge leap ahead, right? Evolution.
That would be wonderful.
Okay.
We'll get there.
Yeah, we'll get there eventually. It's the whole person. How to balance exercising with your daily energy limit. Exercising to strengthen for hypermobile EDS without using up all of our energy for other daily activities. I love this question. So in order to be able to strengthen and engage in exercise that fits this type of diagnosis, I have the saying low and slow. We don't want to go into the weight room and start hitting weights and, unsupervised. That would be disastrous, because we're probably going to injure a joint, have a setback, have a flare up. And a lot of times that could be the thing that causes a patient not to go back to strength training ever. So we would want to be successful in small doses. Hypermobility really needs stabilization first, and stabilization looks like core retraining of muscles. A lot of times muscles that are like our power muscles, like the quads or the glutes or the hamstrings, they might be overdoing a lot of work, while smaller stabilizing joint muscles are not doing a lot of work. So we have to work on both alignment and stability in ways that are low load.
I have an observation of the types of exercises that patients seem to do well in my practice. Can you tell me if this is a good idea?
Yeah.
So I've always been of the opinion that walking is the fundamental of fitness, and walking is something almost everybody can tolerate. And then it seems like swimming, rowing, or an elliptical are the ones that these patients tend to tolerate the most. And that other activity, even strength training, if it's just upper body or isolated movements, if it's more HIIT therapy, if it's treadmill, those seem to be more depleting. Does that make sense to you?
Yes. Walking, gold star. I mean, we love walking. It can actually go towards that limbic system retraining. Walking mindfully and using the breath and using postural awareness hits like so many things together for improvement therapeutically.
Yes.
And in general, the low impact activities that you mentioned, walking is, one of the best, most easily accessible ones. And so then swimming, again, low impact, but lots of good circulation, lots of good all over body movement in swimming. We do see hypermobile shoulder issues with swimming. So the warning sign there would be if you're having pain with swimming, you need to see a PT about it so that you don't re-injure or have repetitive motion that would damage, a hypermobile shoulder. And then with elliptical, that is on my iffy list with this population because of the SI joint hypermobility that tends to cause low back pain.
Rowing? Would rowing be?
Rowing is iffy too.
Iffy too.
Elliptical is my least favorite. Because SI joints that are hypermobile will usually get out of alignment on an elliptical machine.
So your power ranking would be walking,
swimming,
and rowing and elliptical.
Yep.
Okay.
And if the patient is like well managed, doesn't have flares, we're talking, they're living a high quality of life and they want to do elliptical, then I'm going to show them how they can do elliptical with core stability and joint prevention.
I see. Okay.
Yep. And then the other thing that I love is make exercise a functional thing. So the question about not using up all the energy because you still have to go home and cook and clean and do chores and put your kids to bed and all the things. So can your exercise look like dancing with your kids and your family and having fun? Can your exercise look like maybe doing 10 or 15 little miniature squats while you're at the countertop preparing your supplements to take for the day? Yeah. So if we can kind of work in many doses of exercises like that along the way, it can feel less like a chore and obligation and more like we're building up some functional patterns of movement that we're being more mindful about. And so we're gaining more from that. It's not like emptying our battery.
Yeah.
Okay, so next one is for you, Dr. Joe. Right. How can MCAS be tested for digestive issues? I think maybe rewording it to how can we test for digestive issues with MCAS? So
MCAS commonly causes GI symptoms. So I talked a bit about diarrhea, and I would also say burning stomach pain, heartburn, reflux, nausea are also quite common. And from a testing standpoint, the really only thing that is available would be a biopsy on an endoscopy. So when a GI doctor is doing an endoscopy and colonoscopy, normally like a screening endoscopy, they're just looking, right? They're putting the camera down your esophagus and they're looking for anything that seems out of place. But then they can go one step farther and they can take a tissue sample, a biopsy. And there is a fairly easily done test where they can count the number of eosinophils and mast cells, right? in the biopsy. And all that has to happen is the GI doctor has to ask the pathologist to stain for this appropriately. And then they'll go in and they'll count the number of cells that they can count on the microscope.
Okay.
And then they'll give a number. And that the higher the number of abnormal allergic cells, the more likely that you have a mast cell disorder. So that
answer.
can be done.
Yeah.
Now that's invasive,
Yep.
right? And so that's if you're already have an EGD planned and you suspect you have MCAS, then I think that would be pretty reasonable to do. But it's not something that I think most GI doctors are just going to jump to do without some clinical context.
Right. And so that seems like the endoscopy and then with a biopsy could rule out a whole host of other things that could be at play.
Yeah. There's a condition called eosinophilic esophagitis where you have an accumulation of a similar but different allergy type cell that can mimic some of the immediate reactivity and cause chronic GI conditions as well. That would rule it out for sure.
Gotcha.
Yep.
Okay, cool. So that is how a GI specialist could be helpful.
Absolutely.
And maybe the patient could just voice that, like, hey, do you think it's necessary that we do a biopsy here and look at the cells on a microscope?
Or just say, if you take a biopsy, please do this. And be a little forceful, kindly but forceful. This is what I want. This is a procedure happening on my body. I'm willing to cover the cost or pay it, but it shouldn't be for them to say, no, you can't have that done. If not, go find another GI doctor because it shouldn't be hard to do, right?
I love that. Advocating for getting to the outcome that you need to meet your body's needs. Advocate. Okay, this is another great one. Thank you for answering that question. That was really good. Would like to hear ideas on non-pharmaceutical ways to help the pain, swelling, joint issues, and skin issues other than cutting out trigger foods that are known and how to lessen
Cleaning
them
up
potentially.
Diet is great. So a low processed food or minimal processed food diet is essential, very, very important, but it's not going to fix it. And so my next favorite tool would be Epsom salt baths. With a ton of Epsom salts. And so even up to 4 cups of Epsom salts, and you soak for 20 minutes, up to 4 times a week. And the trick is you have to be very careful to make sure you're not overdoing it.
Yeah.
Because this will replace your magnesium and sulfates and will have biochemical effects. And you can mobilize things too much too quickly if you overdo it. So for a very reactive patient, I would start with a very tepid water. You really do not want to scald. Hot soaking bath will be too much, and you need to kind of pay attention to how long you're in it. But if you know you can tolerate it, then this can be really, really helpful a couple times a week, and particularly when you're flaring.
Love that. Epsom salt bath, also relaxing for the nervous system.
It's wonderful.
And also, I'm going to flag the decreased processed foods because that's so huge and pretty doable.
Yeah. When the body sees things that are not food and the mast cell sees chemical stabilizers that have no digestive purpose other than keeping something shelf stable, right? It's just more things to react to. There's more ingredients, there's more excipients, there's more gluten, there's more coloring and flavoring and stabilizers and antimicrobials, more things for the body to react to. So less is more. The cleaner the diet, the cleaner the water, the cleaner the air, the better you'll be. Definitely.
Cutting out all those additives. And I had a patient the other day bring up the issue of leftovers, that she could not tolerate leftovers in the fridge.
This comes from a low histamine diet. So patients put on a low histamine diet are told to freeze their foods immediately and not keep things in the refrigerator. The idea is that certain bacteria can grow on the foods within 24 hours, and the histamine load increases. When someone with mast cell gets put on these mast cell stabilizers, which also work to dampen the histamine response, oftentimes they can eat some of those foods a little bit longer in the refrigerator. This is such a hard thing for people to do that I don't recommend this. Can't remember the last time I recommended this practice to someone, just because it's so restricting. And if you are reacting to food to that degree, then you need more support.
Right.
And you don't want to just rely on, I have to freeze this and I can only eat meat and fish and vegetables that were grown here.
Right.
You can't live your life. And so if you're finding yourself on a low histamine diet, you have some issues that you need to see a good practitioner to sort out.
That's a wonderful point because, like you're saying, that really highlights, it underscores the need for internal changes in the quality of the body, balancing it out.
Yep.
And it's also the risk for disordered eating.
Too many people are coming in with eating disorders.
Yep.
So I'm really hesitant these days to put anyone on a very, very restrictive diet. I think that a lot of times diets are doing more harm than good. And the truth is you do not have to be perfect on a diet to heal. You just have to do the diet that reduces symptoms. But we know that there was a specialty neuropsychiatric group that was taking referrals from a GI clinic. And the patients who came in on a restricted diet, gluten-free, dairy-free, various elimination diets, had a 3-fold increase in eating disorders. So we know this is happening. I see it all the time in patients who've been to multiple practitioners, dietitians, integrative doctors, functional doctors, regular GI doctors. They're eating 4 foods.
Yes.
And it's a big problem.
Yes. It's definitely, it lends itself to another set of problems then.
You feel unsafe when eating.
Yep.
It makes the limbic system more on fire, which sends more signals to the mast cell.
Yes. And
eat 3 times a day. It takes maybe 40 minutes total, right? But you can worry about food for hours.
yes.
What am I going to eat? How am I going to prepare it? I'm eating it. Am I reacting? Okay, what did I have yesterday? Is that what I'm reacting to? Now I'm having it 60 minutes. Now it's 80 minutes. I think the food's in my small intestine. Maybe it's fermenting because I have SIBO. Maybe it's
Yes.
yeast. Maybe it's SIFO. Wait, I don't know. Okay, now it's 90 minutes in. What do I have to have for dinner? I'm not hungry. Should I eat more? What's my blood sugar? It goes on and on
Yes.
and on and on. And these patients are really need some help, and they need not more restrictive diets. They need help feeling safe and secure.
I'm so glad you said that because a lot of our patients coming in with these issues are in a state of worry and anxiety and fear.
Yep. Then that needs to be unwound.
Yeah.
And it's a couple layers deep, but the Gupta program is really, really wonderful for attacking this. Attacking is the wrong word, for softening this.
Yes.
For healing this.
We're like lowering the military
Healing-
response.
yeah, lowering the military analogies. We are calming and stabilizing.
Yeah, totally. And nurturing.
Yes.
I will add to that the Gupta program. Can I put the link in the notes?
Yeah.
That 30-day free trial. Do you know if that's still going on his website?
No idea.
I'll look it up for a reference to use. But then the other thing is that even just the simple diaphragmatic breathing has so much evidence behind it for helping to retrain limbic and help vagus nerve.
Yep. So I'll say I did the Gupta program, so I'm very biased. I love that. Ashok is a good man, and he's doing research, so I like that. Primal Trust is another one that my patients are really, really loving.
Nice.
That's another option. Biofeedback. There's
Yes.
a device by the company HeartMath.
Yes.
It's called the MWave2, EMWAVE2, which is a biofeedback device. That's great. Those are some of my favorites.
That is awesome. So we will list those in the show notes. I have the Gupta program, the MWave 2. What was the middle one that you said?
Oh, geez. Let's see. Oh, Primal Trust.
Yep, Primal Trust. That's a book or that's a program
It's an
for biofeedback?
online program.
Got it. That's
for
awesome.
limbic retraining.
Excellent. And Dr. Joe is mentioning these strategies because they address systemic problems, not just like one problem. It's like the whole system that's the military complex in your body.
Yeah. I agree.
Okay, last question. How to get a diagnosis and help when I can't afford going outside of insurance and doctors seem not to understand how to diagnose and treat. So this is like the insurance network question.
So I think from as There's a lot you can do on your own that doesn't require a doctor, right?
Yes.
You can clean up your diet. You can start movement. You can take a look at why do you have a lot of stress? You can fix your sleep.
Yep.
Those are things that you need to take charge of regardless. And I think that those are fundamentals that shouldn't be missed.
Yes.
If there's trauma, that needs to be dealt with. If you're living in an environment that has mold, you need to move. If you are drinking unsafe water, if you're eating processed foods, those are all changes you can make without a doctor. And I think those go the farthest, because if the honest truth is that the mast cell supplements are fantastic and the medications are wonderful, but they're fundamentally a Band-Aid, right? They
Right.
are calming, they're covering it up, but there's still an issue causing the mast cell.
Right.
And in most of my patients, that's mold exposure.
Yep.
And there's a ceiling on how well I can get someone if they're still living in mold. So
Yes.
if someone is having unresponsive mast cell or just mast cell, and they don't know where to spend their dollars and their doctors aren't helping, take a very good look at your environment.
Yep.
You might need to move. And if you can't afford testing, then I ask patients to spend a week out of their home at an Airbnb or a hotel or a cousin's house, or take a vacation and ask the question, do I feel fundamentally different? Am I reacting to less foods, right? Am I having less symptoms? And if the environment is causing the problem, all of the symptoms should be down about 30%, kind of globally. The brain fog should lift, the fatigue should go away, the palpitations should diminish, you should react to less, there should be less GI symptoms.
Yes.
Right? So globally, you're not going to feel perfect, and the sicker you are, the longer it takes, right? So the kind of people who are minimally sick might turn around in 2 to 3 days. Those who are sicker take longer. But then when you go back to your home and symptoms flare, then you know it's your environment.
Yep.
Right? When they come right back, then you know you're not safe in that environment. You need to move.
Right.
And all of those things can be done without a doctor's prescription.
Right. And without having to go down the confusing rabbit hole that it sometimes becomes, right?
right.
Like
Yep.
from one doctor to the next to the next.
Yep.
So I think that, well, especially we'll mention this in New Orleans, mold is so prevalent here in our subtropical, tropical.
But I see people across the world now, and I've seen people in every single state. And it's not just New Orleans. It's not just the Gulf South. I get mold patients in Arizona because they live in climate-controlled buildings with air conditioning.
Wow. So where it's in the ductwork.
So it's a consequence of the modern building style.
I'm glad you said that.
Yeah.
So do you usually have like a mold question on your intake form?
I ask them myself.
Yeah.
There's just too many layers to this.
Yes.
That I prefer to just talk them through it. And I want to get a sense for their symptoms before I go down the mold train, road, path. I don't know.
Sometimes mold is a trigger word. Like it's going to bring up a lot.
I mean, it is for me when I was sick with mold. And so people bring up their phones to show me their AC. I'm like, I don't want to see it. Yes. I believe you. I know that it's moldy. I just don't want to see it.
Yes.
Yes. People who are living in mold are generally very sick. And so I mention that because patients with MCAS are very sick. There's a difference between I have occasional diarrhea and occasional brain fog, which can happen to anyone, and debilitating symptoms that are preventing you from holding a job,
right?
From completing coursework, from going to college, right? There's a very big difference in scale. And so I may have a patient who, on the intake form, they say they're 20 out of 100 in terms of their overall health, but they're doing great.
Yes.
And then I'll have someone who's barely holding on who tells me that they're like 90 out of 100. And then I ask them, and I'm like, what? I was like, we want to give me another score.
Yes.
And they come way down. So it's really important. It's one of the reasons why I have patients come to me, right? Because I think there's so much you can learn when you lay hands on someone, when you talk to them, when you actually hear the story more than just a form online. I used to do a lot of telemed, and I much prefer in person.
Absolutely. I'm so glad we have in person.
Yep.
And I'm so glad I get to see you in person at work. It's so fun. Is there anything else you want to add to the conversation that we didn't hit? I know we were trying to kind of make it within our hour segment so we don't go too long, but what else?
Don't forget the gut. The gut is extremely important for calming mast cell response. So lots of probiotics. That's very important. Some patients need to stack treatments. Some people need the H1, the H2, quercetin, resveratrol, curcumin, but then they also might need prescriptions on top of that. That may be ketotifen, it may be cromolyn. I'm not a big low-dose naltrexone person, but a very few patients have responded very well to that. Most haven't, but some have. And so there's lots of options here for patients to get their symptoms down. And sometimes we can get it in the first couple weeks and you get that wonderful email, but sometimes it takes a couple permutations and tweaks of their program to get them there. So don't feel like if you've seen a doctor and they gave you their first shot, as long as you get the sense that they have a plan B, C, and D ready to go, don't give up on them. Just give them more time and let them listen to your response and tweak the program. Because I may have a patient who does awesome with the H1, H2, but feels like crap on quercetin and curcumin. And those patients, I may go more down the pharmaceutical route. Whereas if I have a patient who gets on the quercetin and curcumin and starts feeling better, but is not doing well on the antihistamines, I may add more natural therapies. There's a supplement called All Clear that works great. And so I may add that one on, right? So it just depends on the patient's response.
Wow. Yeah. And you're really underlining the way that it is navigating a path together.
Process.
Yes, a process, and the relationship between the patient and doctor is so important to have that process unfold so that you're really getting under those layers and getting to the answers together.
Which is why if you don't trust your doctor, you're in for a rough road because you already feel like shit if you have MCAS.
Yeah.
And so you don't want to have another layer of stress that, your doctor doesn't have your best interest in mind.
Yes.
So find someone you trust.
Find the right provider. I think there is some fatigue sometimes in the sense of just going to see another doctor. And, like in I think it's medical system that we're in. There's so many specialists.
Well, I will say if people are looking for practitioners and they are not in Texas or Louisiana and they are unable to travel to see me, Dr. Neil Nathan has a list of practitioners that he's trained.
Great.
And if he's trained them, I'm sure MCAS has come up. And so it's NeilNathan, Dr. Neil Nathan. And I think it's neilnathanmd.com. And
Great.
There's a practitioner list there. People can reach out to someone in their state.
That's awesome. We'll list that link on the show notes too. So that way they have a reference and hopefully can find a practitioner who's trained in that, who's very well versed and can put on their MCAS hat just like you did tonight. Thank you.
That's right. Yay.
Thank you so much, Dr. Mather. I want to add that if you want to tune in for our next show, we want to be able to follow this up and talk about EDS, dysautonomia, some of those other things we mentioned under this umbrella, this triad that runs together, all around those connective tissue disorders that can wreak havoc on our GI too. So
awesome.
I'd love to have you back.
That'll be fun.
Again.
Let's do it.
Thank you.